Next, I'm going to invite Dr. Sanghamitra Kanungo. She'll be speaking on when to switch over and how to choose the alternative.
Good evening, all. So what do we choose looking at the features, whether be it OCT pictures or fundus picture? Why do we need to switch? Whether it's because of non-resolution or reactivation, and what do we switch on to? So these are the things I would go through some of my cases to let you know what we can do next. So why there is a need for a switch? There's a beautiful paper on IOVS which tells us that despite favorable clinical results, exudations results in a number of patients after repeated administration over time. Patients suffering from disease recurrences may have developed an acquired resistance to the anti-VEGF therapy, which is known as the tachyphylaxis. So first, let's go case by case. The first is the diabetic macular edema. So this was a 74-year-old male, known diabetic for 34 years, had hypertensive for 30 years. This was his presenting picture in the right eye, 6/12 with macular edema. He took 4 subsequent injections of Accentrix. His vision his vision improved to 6/9, but again returned back to 6/12, again returned back to 6/9, and he continued with 6/9 over the period of time. So with 4 Accentrix, he was good to go, with all his systemic parameters remaining controlled. Let's look at his left eye. So this was his left eye. He also had a left eye macular edema with a 6/12 vision.
I'll tell that.
He took 6 Avastins in that eye, because as he was taking Accentrix, he couldn't afford to the same Accentrix in the other eye. So he took 6 Avastins. So this was at the end of Avastin, this was at the end of Avastin. His vision remained 6/12. There was on and off macular edema reducing, but again it was increasing. At that point of time, we shifted him to Accentrix again, and 2 Accentrix, he was good to go with 6/9 of vision. And this persisted for a longer period of time. Now this is a 58-year-old doctor, nephrologist, who presented with 15 years of diabetes, which was well controlled, with a macular edema, but his vision was 6/6. So as the study goes, we observed him, again 6/6, gradually macular edema is increasing. At this point of time, actually, I was a bit jittery, and he was also. Though his vision was 6/6, we injected with Eylea. This was following Eylea. Gradually, his macular edema subsided, and at the last visit, he's still persisting with 6/6, and macular edema is almost resolved. This is his right eye. So the left eye story is like, again, it was 6/6, but again there was macular edema. We observed him. Now the macular edema is increasing. At this point, we injected again with Eylea, as his right eye was doing good with Eylea. His left eye also, we had put him on Eylea. But after 3rd Eylea, at this point, there was no improvement. So we injected Pegenex. After 2 injections of Pegenex, the macular edema subsided, and he continues with a 6/6 vision. Now this was a 55-year-old male with a diabetic and hypertensive. So here he was injected with Avastin. His macular edema was gradually increasing. He was persistent on taking Avastin because he could not afford to. After about 7 injections of Avastin, when we saw the macular edema was quite persistently increasing, we persuaded him to take Ozurdex, and after that he took Ozurdex, and his macular edema reduced. Now what the scenario with eyes with cataract having diabetic macular edema? Now this was one of the patients who had a grade 2 nuclear sclerosis, had a macular edema, underwent cataract surgery. Just a week before, we injected an Ozurdex, and a 2 months, 2 to 3 months follow-up. The second photograph, which tells about 2.5 months follow-up, his macular edema is well controlled, but he has some amount of hard exudate in the macular area. As we know, post-cataract surgery, there are some inflammatory pathways also that act. Therefore, Ozurdex works good in such patients, and we have had a number of cases in this regard. Now, this was another one patient who underwent a cataract surgery, was injected with Ozurdex, and month probably or 2 months following the cataract surgery, his macular edema has subsided, and there was an improvement in vision. The use of dexamethasone has been well documented, and it appears to be safe and effective procedure for treating patients with concurrent macular edema and cataract. And there was a significant improvement in best corrected visual acuity and reduction in the central macular thickness after the surgery. So this is a patient where he has almost a chronic macular edema, and you can see a round hard exudates covering the macular area. This is a chronic macular edema, as you can see from the OCT. In such cases, I preferably choose to go with Ozurdex because it's a longer acting and works better. All said and done, in diabetics, the glycemic and blood pressure control remains the hallmark of prevention and progression of diabetic macular edema. It is also important to assess the renal status and the anemia. And if the patient is on glutazone or prostaglandin analogs, one should take care of it. Switching to steroids, if non-responding to anti-VEGF, but difficult to maintain a frequent follow-up visit because Ozurdex, the steroids can work for about 3 to 4 months. Pseudophakic patients who have reached a plateau, persistent intraretinal fluid is there, in persistent edema needing cataract surgery, occurrence of systemic vascular events in the near future, associated features such as extensive hard exudates and presence of hyperreflective foci in the OCT or eyes post-vitrectomy. As we know, anti-VEGFs stay for a very short period of time in such patients. Let's move on to the next disease, retinal vein occlusion. This was a 75-year-old male, known hypertensive, and on Travertan, his open-angle glaucoma. Intraocular pressures were well controlled. Best corrected visual acuity was counting fingers, a good amount of cataract also. This was his OCT pictures. After giving anti-VEGF, this is what happened. There was a traction in the macular area. So this patient underwent cataract surgery along with vitrectomy and intravitreal. So all cases are not the same. The next case was a 55-year-old male. He had a BRVO with a hypertensive for 10 years. We were lucky, and the patient was lucky with 2 Rajumab. The edema went away, and it persisted for a long period of time. But not all are very lucky. Here is a patient, after 4 monthly Accentrix injections, the edema did not come down. So one had to switch over to Pegenex. And after that, the edema came down. This was another one patient with inferotemporal BRVO. After 3 Avastin injections, the edema did not come down, so we had to go on with Rajumab. After 2 Rajumab injections, the edema came down. This is a 72-year-old male, known diabetic and hypertensive, with a stroke 3 months back. He was not a known glaucoma patient. Intraocular pressure was 16 with CRVO. This was the macular edema, and we went ahead with Ozurdex in the first go. So this was another one patient of CRVO who underwent 6 injections of Accentrix. Still the edema was coming and going. After that, as the patient was from a longer distance, could not come for follow-up, so we put him on Ozurdex next. The next scenario is a choroidal neovascular membrane. This was a 61-year-old female with best corrected visual acuity of 6/60 in the left eye. This was the amount of edema, hemorrhages, submacular hemorrhage, and the CNVM that she had. With 2 Pegenex injection, the hemorrhages had cleared, and she gained back a good vision. A 66-year-old female, known hypertensive. This was a very interesting case, a huge PD. I was actually very frightened to go on with the anti-VEGF, but when I injected the anti-VEGF, she responded to 6 Accentrix. Gradually, the PD was coming down. Then again, it recurred back. Then she took 5 Eylea. Again, it was coming down, but again, it came back, and 2 Pegenex And the last picture, she is 6/18, again the edema has come back again. So what more next? Maybe the newer drug, faricimab, we can try. Now this was a 52-year-old female, known hypertensive, again a PD. This was submacular PD with 3 Eylea injections first. The PD gradually decreased, but again it came back. We gave 2 Pegenex injections. Still with that also it increased. Then again we went back to Eylea. Now it's, we have just given Eylea recently. So this was again a 63-year-old male. Due to shortage of time, probably I will not cover that. So to conclude, we are very lucky now to have 5 effective anti-VEGF agents and many, many biosimilars. Shifting from one anti-VEGF to the other, if after 3 injections it is not responsive or it is coming back, is a good choice. But remember that variation in individual patient response may lead you to drug choice that may counter results also. You will do your patient a disservice if you think that drug X works best for the patients, and if responsive to anti-VEGF agents is inadequate, corticosteroid is still an option in certain cases. Thank you. You are the best judge, so think wise.